Good morning and welcome to our monthly webcast. This is session number 45. I'm your moderator, Samir Mehta. Thank you first of all for the numerous messages which we have received and the personal interactions at India Live and at the American College of Cardiology's meeting. Your feedback has been extraordinary. We are also delighted, which I'm sure Dr. Sharma will inform us in his first slide. We've hit our highest number of page views with last week's session. Sameen, congratulations to you. And first of all, I also must congratulate Anu for the amazing number of interactions we have received about her CTO skills, her abbreviated right to the point retrograde technique. It must be a great feeling to have a resident CTO expert in-house now.
Well, you want to answer that? Yeah. I mean, clearly that, everybody techniques are different and we have a lot of questions on the blog, but more important is if we show this. Remember last month actually, when we showed that our viewer was about 7,600 and around like 7,600. Because of this, so much, it took about what, 110 minutes? The live webcast?
It was 108 minutes, yeah. And I can tell you that the number of messages, I don't want Anu to make her blush, but the feedback has been extraordinary, particularly pertaining to her skills with the retrograde CTO.
And I can tell you that speaks for the numbers. Basically, it clearly, and see here, I was saying last time that we need to hit 10,000 by mid-July or December, and we had 12,000. Now it's still going because right now this is the February, and of course the early part of March. So and then of course there are a lot of question answer which we still have to answer. We're quite busy, which on ACC website, but having a 12,000 hits, I mean, unprecedented. We never thought we'd reach there. And this is all because of the technical skills and step by step, which Anu mentioned that how to do it in a simple way. People can use various complex ways, but just do a simple, try to avoid as little as antegrade dissection. And that is what has come up now in the recent trials, that your STAR technique of antegrade dissection are associated with higher restenosis as well as stent thrombosis, and therefore many of the devices which are being made for antegrade dissection, I'm sure going to face a big challenge in this upcoming our interventional arena.
Sameen, although this week with the CIT meeting in Beijing we'll get more accurate numbers, but there appears to be also a steady rise in the listeners and the viewers from China.
Absolutely.
For our Chinese viewers, once again, Ni Hao. I hope you are able to watch our Chinese simulcast, and if you have missed any sessions, you can go back to the archived sessions.
Nope, I just got it.
Sameen, tell us about the case you have, a very complex bifurcation coming right on the heels of the DK crush presentation at ACC.
Absolutely. And we can go through our the slide set with the support we have with Abbott, Boston Scientific, Medtronic and AstraZeneca, and of course these are the disclosures. Now, this is a 73-year-old male who presented last month with crescendo class 3 angina and axial dyspnea. Patient actually has baseline severe mitral regurgitation but has refused any treatment because of history of CVA. And then of course he had a stress test which was ischemia in both in anterior and lateral wall. And of course had a cath which led to 3-vessel disease, and will show you clearly the same because of the high syntax score, established severe MR, recommendation of the heart team discussion should go for surgery. So we showed it again with the cardiologist and the surgeon, patient and son who is the spokesperson for the patient, and Anu spoke to them. They declined. After surgical consultation, patient had a stent of the high lateral, ramus and LAD. It still has ischemia, still has some residual angina, and we done good medical therapy as shown here. More importantly, now Anu can take us through the angiogram, which was a 3-vessel disease, although non-dominant right coronary artery.
So if you can see here, tapering, but left main, but mild disease. He had LAD disease. You see a stent in the LAD. You have a stent in the high lateral. And ostial circ, same, is a dominant circ, less than 30%. You see some calcium, but not heavy calcium, mild calcium along the entire circumflex. But what you see is a bifurcation, distal circ, LPL. You can see it here. So LPL, which is a moderate size vessel, but a long lesion, more than 20 millimeter, and a true bifurcation of Medina 111, starting before the bifurcation, extending into the side branch and extending into the main vessel.
Yep. And this is our goal now. Now the syntax score is 16, good LV and non-dominant right coronary artery.
And this is its LV function. Yeah.
And patient was discharged on clopidogrel, and now with the 2 long stents already in the ramus and the LAD, and now the bifurcation, we will routinely, usually we don't test the platelet aggregation, but in this case, knowing that despite the age and the CVA history, that we can still necessary, patient can be switched to ticagrelor if the PRU is less than 230, more than 230. So we'll test it, and that's what in rare cases, at present, those who are high risk, we are using this dependable antiplatelet therapy of whether ticagrelor or prasugrel, but some cases where we are reluctant. We don't want to use it unless it is necessary, like this particular case was history of CVA, although we know that CVA was a contraindication for the prasugrel based on the trial TIMI 38. But there was no interaction of the CVA with bleeding or event rate in the Plato trial. So that the patients need a stronger antiplatelet, dependable antiplatelet therapy. Our goal has been, in those cases, we use the ticagrelor, and that is, we are going to test it now. But believe me, when you test, almost 80% have a good inhibition. With a PRU less than 230, you don't need to change it. If it is more than that, then those cases will change. So now in this particular case, because the high-risk ischemia is appropriate all throughout, was appropriate then and is appropriate now, and while we were trying to get ready in this particular case, should we do a IVUS in some calcium of the main vessel? Probably not. No. And the question is that 2 DES for bifurcation lesion and the newer devices for calcified lesion, because our goal always have been to update our viewers with the recent one. Advances which comes latest publications and so, and the issue of the 2 DES, 1 stent versus 2 stent by various technique of the kissing, crush, or T-stenting or culotte has under the proponent and I would say opponent of various techniques, but majority is still saying that 1 stent is good enough, but we also know that correctly done 2 stent, and this was our we published in Clinical Cardiology, that as you see in the right side of the middle, that having a 2 stent and 1 stent, and the MACE rate is in the red and TLR is in yellow, that 2 stent strategy is not bad. And same also that not a higher stent thrombosis. So it seems to be that correctly done 2 stent strategy may be okay. But one technique which has come really superior to any other technique, single stent or 2 stent, is the DK crush. And that basically involves that you put a stent in the side branch, you crush it with a balloon, do a kissing balloon dilatation, that's a first kissing, and then you put a stent in the main vessel, cross it again, and do a second kissing balloon dilatation, that's a double kissing. And that's the DK crush, really proponent being from China, and has shown in their original trial after DK crush 1, the DK crush 2 showing compared to conventional, which is the blue, and the DK crush in red, showing the lower MACE rate, TVR and restenosis, although there was no difference, rather slightly higher stent thrombosis with the DK crush. But clearly this was the early of their randomized trial of about 350 patients, and then led to the latest presentation last week in San Francisco by that group for the left main, because that has been a big issue, that what should be the right technique for the left main, and that's the DK crush 3, which showed the data of the patients about to 400 plus. The majority of them were distal left main, and compare the DK crush to a culotte, and basically found that as you can see here, that the DK crush in the blue and culotte in red, the event-free survival was significantly lower. The survival was significantly higher with the DK crush group compared to a culotte. So basically means the less MACE rate and overall less event rate and TVR, which individually shown the composite of MACE 6.2 in the DK group versus 16.3 in the culotte. These are the distal left main at 12-month follow-up. Cardiac death was not different. MI was slightly lower again in the DK crush group, so also the TVR, and no difference in stent thrombosis. While the earlier studies did show slightly higher stent thrombosis, but clearly now in a large vessel did not make any difference. And they actually have a pre-specified with the angles and diabetics and high syntaxis score. It looks like in every category, DK crush came out as a winner in these cases. At the heel of it, there's another paper came out in the JACC cardiovascular intervention about from the BBC1 study. Remember, BBC1 study was complex strategy of 2 stent versus 1, and data showed at 9 months, 1 year that you had higher MACE rate with the 2 stent versus single stent, which is a simple approach. But now what it showed basically that as far as the quality of life is concerned, that questionnaire, angina and quality of life, both were identical and both showed improvement at follow-up. So that as far as symptoms are concerned, 1 or 2 stent strategy was identical as shown here. So quickly go to the second while we are getting ready with the guide, and so that the newer devices for calcified lesion. We know the calcified lesions are a problem. We all know that because many times angiography underestimate the calcium. More also, the calcium cause more procedural complication, unexpended stent, and higher side branch closure and restenosis. So clearly, at present, only device we have after the microneeded calcium using either the flextome or angiosculpt, then the heavy calcium using rotational atherectomy. Problem with the rotational atherectomy, as we showed the 2 months ago, that even the latest trial of the Rotexes that still have a higher late loss. That's a major issue. It has better procedural success, but higher late loss in the rotational atherectomy trial. So that while rotablation is very essential in many of these cases, but has not shown to be beneficial in terms of reducing the MACE and lower restenosis at follow-up. Now, actually very interesting, this is the data presented in TCT, pooled analysis from the acute coronary syndrome trial of the Acuity and Horizon, and basically had 32% patients had a moderate to severe calcium, which is a type B of ACC-AHA. Remember, none too mild is type A, and 32% of these patients, and you see the outcome of these patients, that those who have moderate to severe calcium, clearly the heavy calcium were excluded. We don't randomize those cases in the trial, but clearly that high calcium had a higher MACE rate, higher the stent thrombosis and TLR, and the myocardial infarction is the little trend. The key, and of course higher death rate. Very important that calcific lesion is a predictor of long-term MACE, and therefore it's while the rotational atherectomy is very good and we believe it, and we do about 9 to 10% of rotablation every month of our 450 cases, but it really has not shown to be a real benefit in terms of reducing the restenosis or changing the long-term outcome. And of course, these are the various devices that we can use. Just a high pressure balloon dilatation of the non-compliant balloon, go to high pressure, or in a mild to moderate calcified lesion, use a flextome or angiosculpt. Now, angiosculpt actually now available in various sizes of the 6, 10, and 15 millimeter, and of course the cutting balloon or flextome available also 6, 10, and 15 really comes handy in osteal lesion and mild to moderate calcium. For heavily calcific lesion, only thing we had available is the rotational atherectomy, and basically they work by scoring the plaque, cut the interelastic lamina so that vessel expand and your subsequent stent expansion occurs with both flextome as well as angiosculpt balloon. There are some data to say that if you use a stent and you pre-dilate with a balloon or direct stent versus go angiosculpt, that you get a better your predefined stent lumen cross-sectional area of more than 5 millimeter square, and no matter which lesion morphology it is, but more so in the calcific lesion, that while your pre-dilatation of the balloon may not be enough, that using the angiosculpt get you the better stent expansion. And of course the Rotex trial, which is now published in JACC last month, goes with the same, that rotational atherectomy did not change the long-term outcome MACE, rather numerically was high, the event rate was slightly higher compared to the with the PTCA group. Now, there's a new device, and this is what I'm alluding to, that what's new now, that is the device called orbital atherectomy. It has a very unique mechanism that while the rotablation works on the wire with the longitudinal, with the high speed on a wire, that this is the crown, the burrs rotate in an elliptical fashion in the orbit. So basically the same burr, if you change the speed, it changes, it increases the lumen, same size of the burr. And this is a very important, that in this increased speed is the increased centrifugal force. Very important, that therefore you need to increase the lumen, you just increase the speed. And this is where the word they are calling as sending, send, as if you are just sending the plaque, compared to the ablation which we do with the rotational atherectomy. And therefore it has gone through various trials, and this is a quick setup. With the eccentric crown, the Viper wire, which is 0.012 compared to 0.009 of our rotational atherectomy, and the setup looks similar to rotational atherectomy and the electrically controlled, much simpler device setup compared to what we have for rotational atherectomy. And what has shown is that continuous flow of the blood and saline minimize thermal injury. We can do it 2 minutes. Yeah, that. Clearly, that's therefore less debris, less thermal injury, and less peri-procedural enzyme elevation was the theoretical question is, did it happen? And that is, we have Orbit 1 trial done by Parikh and Chandra in India with of the 50 patients, and having a MACE rate of about 8% at 6 to 9 months, and we now have data of 3 years. But more importantly, what was presented just last week was the Orbit 2 trial. And Orbit 2 trial was the prospective multi-center trial of 443 patients, and all were heavily calcified. Because apparently, ours actually was just learned that there is no clear indication for a heavily calcified lesions, even rotational atherectomy. But severely calcified lesions in a 49 US sites with the 443 patients underwent orbital atherectomy, and 30-day follow-up was presented in 98% of cases by Dr. Chambers. And primary endpoint basically were the same, or MACE rate with a MI of more than 3 times CKMB, and it involved the severely calcified lesions and all complex. And basically what did we find? That the 30-day MACE rate was 9.7% in these cases. Now we remember comparable in Rotex trial, this was 13-14%. The keys US CKMB of more than 3 times was 9.7. Majority of them was non-QAMI, rarely QA, and TLR and cardiac death as shown here. And there was because there was no control group, so they were pre-specified goal to begin with. They needed to be above 83% in terms of the 30-day MACE free freedom, and got to an 89.8%, and so also the procedural success, which was the performance goal based on the data. It was not a randomized trial, 82%, and they got 89.1 with, as I said, MACE rate of under 10%. So seems to be that another device which will come up very important in cases of our calcific lesion, where we have relied on only one device, which is rotational atherectomy, but soon the data looks quite good, and I'm sure they will be presented to FDA in next few months after data cleaning, and we could have another device for calcific lesion in next before the year end. Now, just to say, orbital atherectomy is available for the periphery at present, but coronary is the one which we do not have indication at present.
So, I mean, clearly there is a need for another device for plaque modification, as many viewers would have observed, having watched numerous cases where we continue to use either rotational ablation or angiosculpt. The benefit when you present some of the initial data, and I understand you are going to be the principal investigator of the trial?
Well, I mean, we don't know. We want to do this trial because, to me, I think it will be a very important.
So the one of the advantages appears to be that a single crown based on the speed can be adequate.
Yeah, that is basically the goal. I mean, it goes through 6 French. So you need to get a lumen of 3 millimeter. By changing the speed, 1.5 bar will give you a lumen of 3 millimeter.
Without ever having tried this, I can tell you the wire will be better than the rota wire.
Oh, that actually Viper wire is the one at present Anu uses rarely in those retrograde, exteriorization of the stent. Very stiff, nicely wire compared to the rota wire, which in my opinion, is the Achilles heel of rotational atherectomy. This wire will be much better, 0.012, and has a very torqueable.
Samin, before Anu starts the case, another quick follow-up. There has been some criticism with the DK crush trial that, not too many people are using the Coulette technique, and although the cases and the subsets are different, how do you think that would compare with SKS?
Well, the point is for the distal left main, that is true for when they did a DK crush 2. For DK crush 3, I believe in a large vessel, you need 2 stents. Again, there is always maybe my personal bias, because if you have a large vessel involving the distal left main, where both vessels are involved, that clearly it's a strategy of 2 stents, and these are the large vessels. So that whether you use a quick kissing stent technique, that's what we use and we favor, particularly for the left main and sometimes with a large bifurcation, or use a DK crush, which is a little complex. Multiple steps are needed, and although in the study they did show slightly higher fluoro time and contrast use, but overall from those investigators which are expert, I have used DK crush in about 5 cases. I can tell you, it takes double the time than what we do with the kissing stent technique.
Well, I think eventually it's going to be what impacts which does more of the Carina shift. Anu, take us through what your plan is for today.
So if you can see the angiogram, I just have it in the caudal view. Both the main vessel and the side branch, you have significant disease, and the side branch also has long 20 millimeter lesion. So I think in this situation, plan should be that you should end up with a 2 stent strategy. Now I can just let it play here. So like I think we discussed this before, the angiogram, you give dye, that you see not a tram track calcium, but at least you see moderate calcium on one side of the circ. So just be prepared that you may have trouble in getting your device down in the circumflex. The question always comes, which is the best view, and other thing is which vessel do you wire first. There's no hard and fast rule which vessel you wire first, whether it's the side branch or the main branch. All depends on how tight the lesion is at the level of the bifurcation, and which vessel is angulated. Many times you can have a diag that is diseased, that is straightforward, and then an angulated LAD. You may have to wire that first, versus sometimes you may have angulated diag. So there's no hard and fast rule.
But I think overall, complex lesions should be wired first.
Yeah.
Whether it's a side branch or main vessel. I think that's a main statement, because otherwise your wire will spin and will entangle with the previous wire.
And what wire you will use for the side branch is same. Always use the preferred hydrophilic for the side wire, or the most difficult vessel, whether it's the main or the side branch, and then you can go with another workhorse wire on in the second branch.
Samin, I'm sure some viewers may even argue that just keep it simple. They will even cite the British bifurcation study that just do a simple provisional stenting here.
The question with provisional stenting is the side branch is diseased, long disease, and it's a major side branch. If you lose it, provisional stenting means if you try to balloon dilate the side branch here, you will have dissection here. You cannot just say, now if you have 5 millimeter or less than 10 millimeter involvement of the side branch ostium, maybe you can say just balloon it, stent across and come out. When you have a 20 millimeter lesion, you cannot just say I'll do PTCA and come out. If you see the significant disease when you do PTCA, you will end up with a dissection.
And I think that's a very important point. The proponent of the 1 stent and 2 stent strategy, I say at present, based on our understanding of the 2 stent strategy, that you do correctly, you are not inferior to 1 stent, and goal should not be 2 or 1. Our aim should be that which case will likely to need 2 stent, and you go with the 2 stent prospectively rather than a bailout. And this is a case, as Anu mentioned, with a long lesion. Likely you will not come out without putting a second stent in the side branch. So strategy in this particular case, I would make it a strong case in this particular. I gave an AHA bifurcation talk also, that this is kind of case. If somebody shows me, I said it's a large vessel of the side branch, 2.5 millimeter plus, long diffuse disease involving ostium, go with the planned 2 stent strategy rather than conventional, where in about 25 to 30% of cases, actually to be precise, 8 versus 32, 8 to 32, because some trials showed 8%, some said 32, but about 25% average, 1 in 4 will require second stent, and putting a second stent through the main stent with now angulated branch, the chances that you'll come out with the good results will be less than optimal. So with that note, I think we decided to go with the 2 stent approach here, but clearly the very important also point is that you need to debulk these lesions, because otherwise going to a very crazy pressure cause dissections and perforation. So these are the long lesions, moderate calcium, as you saw it in the main vessel. Our goal will be that we debulk with a high pressure or with the angiosculpt balloons, and then subsequently we decide. Okay, now go. What we are doing now?
So same, we took a hydrophilic wire to the side branch. I just want to make another question. Come here, 1 second. Yeah. Just one other point that I wanted to make is this is just a cine to show how much calcium is there in the circumflex, that we just have to be ready for now one wiring the circumflex. If you see here the LPL branch, as soon as you have a branch, then there are multiple branches in the main branch. So I think wire was just going into all these small branches, in which situation you may have to have just any kind of your semi-compliant balloon just to get your wire in the main vessel. Knowing that it's a long lesion and a tight lesion, you can't go with the cutting balloon to do your atherectomy, but we do have.
This is very good.
You want to try?
Sameen, first question has come to you right away, that did you consider or will you consider IVUS here?
Well, actually they did the IVUS for the proximal circ at the time, at the earlier, pull back a little bit. The question is the same, that would you change anything based on the IVUS? If you find, we know clearly the IVUS is more sensitive. Angiosculpt, yeah. The IVUS is more sensitive to find the calcium, but we change our practice based on the angiogram. So this particular case, I will know, since it's not a heavily calcified, and heavily calcified is that you see the opacity irrespective of the cardiac cycle, and there is a tram track that both walls are calcified, which is not the case here. Let's do the ostium again. Yeah, there seems to be one wall here. So even now, question is, if you find the calcium, little pull back 1 minute. Yeah. That if you find a calcium, what are we going to do different? In this case, since the lumen is reasonable of the ostium main vessel, because calcium is in the main circumflex. So that is a good case for our atherectomy techniques of the angiosculpt and flextome. Take a picture.
Sameen, another question has come. Which is your preferred wire to prevent wire entrapment?
Is a hydrophilic wire, though, hydrophilic wire, probably you can leave it in the side branch and they are easy to come out.
Yeah. People do talk about the polymer getting stripped and so forth, but remember, these are more of a theoretical. There was some earlier data with the earlier hydrophilic, but those coatings have changed since then, and it still do the same. Yeah. And therefore, this 2.5. Yeah, 2.5, that we prefer usually the hydrophilic wire in the side branch. We actually try to avoid using run-through. Run-through is our workhorse wire, because we have seen some difficulty in taking the wire out once it is jailed in the side branch, but hydrophilic comes quite well, and many times you just have to jiggle it, and if required in a rare case, you can use a balloon into the proximal part of the vessel if there is a problem in pulling the wire out. As long as the wire is not in a 7th branch, we can pull the wire a little bit.
I left it there, it keeps coming out.
Okay. Yeah, now we are at the ostium.
This is the distal, right?
Yeah, we're going to distal now. This is the 2.5, 10 millimeter angiosculpt. Advantage of the angiosculpt is that you can go to higher pressure, and whether people do ask all the time that do we have any different lumen gain, angiosculpt versus flextome, and I can tell you answer, I don't have any answer, but I definitely want to do that OCT and IVUS measurement blinded in about 50 patients in the osteal lesions, the using angiosculpt versus flextome, and see which one gives you the better lumen. And now particularly OCT is very sensitive, can give you the cuts by the device, and so we'll have that answer because prospectively, because there is no data to compare. You have to do it again. And always what Anu is doing is passing it again just to see and do a second inflation where hopefully the wire changes in a different direction, and so, and see the resistance. I think we need to go a little bit more in.
Okay. Okay, you're done.
A little 1 millimeter more.
The second question always comes is, which branch you want to dilate first. All depends on what is your strategy. Since we are going with the two-stent strategy here, it doesn't matter which branch you're going to do first. But if you are planning to do provisional, you have to do the main vessel first.
Very good.
Then you do your side branch and then stent the main vessel. So if at all there is any plaque shift, so you do your main vessel, there is plaque shift into the side branch, then you do your PTC of the side branch, and then you have a good lumen of the side branch, then stent across in the main vessel.
Samin, based on your presentation, this would also be a kind of a patient who may benefit with the orbital atherectomy?
Yeah, I mean, I think this is again, we since I had not used it, question is that how can you get a 3.5 millimeter lumen nicely with the device, which I was told yes, but I would say that this is a good case that we, with a 7 French guide which are using for likely for 2 stents, that have a less resistance in my opinion, because if I decide with a rotation atherectomy for the main vessel, as you see, it's a large vessel, 3.5 millimeter and so, and would have been a little difficulty using a bigger burr. Yeah, we can do it here. Yeah.
Yeah, I'm surprised how much resistance you're having there.
Yeah, this is a 3.5 angiosculpt. Let's do it. And what I say always that once you're...
We are too proximal.
No.
Too proximal.
Is it too proximal?
Yeah, 100%. Too proximal. There's no disease.
That's the bifurcation lesion.
Doesn't matter. I think you have to
so
go with
many time in the calcific lesion and tight lesion, your nose may go, so you can just dilate softly.
See
the dilate softly, so that gives you the room to go in.
No.
Too proximal there?
No, there's no disease there. This is just the calcium not letting it go.
Good, try
there are 2 ways. You bring back, go back again with the... Now if it still doesn't go,
just dilate
go
there
with
and...
I don't know, because there's no disease there.
No,
But stent will cover that area anyway.
No, I don't know.
We need to bring it up to that area.
You can go with the regular balloon 1.
Yeah.
Right.
Other thing is...
3.520 high pressure.
We may have crisscrossed here.
Or other question could be here that you could be crisscrossed. That's another point. So what you could do it, bring this back into the guide. No. Take the wire back. No. Don't leave it there. Pull back the circumflex wire. No.
Very difficult to wire.
Circ. Yeah. Not the OM. Okay. So therefore, Anu decided that let's go with the high pressure, which is 3.5. 3.5 NC track.
So other thing that you could have done is recrossed. Definitely do not recross the side branch because we have done PTCA, long lesion.
Yeah, it will not uncommon that it could be just the wire, twining issue. Yeah, but anyway, let's go. This high pressure goes, that tells you should be no problem. Good. Go up.
Went very easily there.
Yeah, and it's a 3.5 NC track. 14.
Down.
Want to go a little further or no?
This is what we had predicted, that when you see this calcium, you know your device movement will be difficult. So you just have to be ready for this. Go back a little bit, right? Go up here.
So I've gone 16 atmosphere, so that we need this to be nicely open, so that hopefully not issue with the post dilatation. which if we put a 2-stent strategy, you need to post-dilate. While the question has been that if you don't put a 2-stent, you may avoid kissing balloon, but if you put a 2-stent, then you need to do kissing balloon or serial balloon dilatation.
Okay,
Right.
good.
Take a picture.
Okay, yeah, take a picture and then we get the stent. We take a, you want a 3.5?
Or
3 or
Some recoil already in the
3.5,
side branch.
Yep, which is expected.
No, 4 will be too big. Sir, 4.
Yeah, 3.5 would have been my.
Yeah.
Okay.
Mega.
3.5. Though it's the long legions, so we are going to use a 2.75. Question is 28 versus 32 for
Means 33.
33. 2.75 33 and 3.5 33.
I think a 28 will be okay, no? We took a-
Samin, are you using more FFR these days for assessing the functional severity of side branches, considering that anatomy could be and geography could have its
I
shortcomings?
mean, we actually
Hold on.
personally
You
not.
want a 33? 275,
Both
33?
33, yeah, 275 33 and 3.5 33. Yeah, no, but the key is that if
Give me
you
the
want to leave it,
main branch first because it's difficult.
if you want
go
to leave the main, you want to leave the side branch and you have a concern, then I would say the appropriate strategy. But we learned that many of those, unless patient having any chest pain, you just close your eyes. As long as there is no dissection, there is no EKG changes, patient having no chest pain, you leave it alone. And I'm surprised actually. I would have predicted, based on the my personal experience, that many of these patients do have chest pain from that side branch. But all the trials actually have shown that that's not the issue. That even with you leaving this tight lesion, tight means 70-80% lesion in the side branch with a good T3 flow does not cause more angina. And that we learned in our Nordic Bifurcation 3. Yeah, see, because of the difficulty going into the circumflex in this particular case, Anu decided to go with this is a 3.5 33 Giants expedition, and that it's having a trouble despite such a high pressure balloon dilatation to 16-18 atmosphere.
Take a deep breath.
Yeah, pull back and go.
Diknicha. Diknicha.
And you see that we try not to jam the guide. Now a lot of people will push the guide and so forth and guide induce injury, but I think pull back and go with the speed once again will be the way to go, in my opinion.
I think we need a second wire. It's not going to go.
Or we go with once again. Now we can go with angiosculp. Once again.
Good.
Yeah, good.
Okay.
See? Second
So-
speed always. Go distal now.
So what did you do different there?
No, we pulled back.
Okay.
And speed.
I think couple of deep breaths helped.
Good little distal.
Yeah.
And now, just out of curiosity, what was the language you were talking to the patient in?
Russian.
All right.
We
So-
actually have a very good big representation of Russian
you have
patients.
to know few languages when you're in New York.
All right.
Spanish and Russian.
Got a resident CTO person,
Speak Russian
a
too.
Russian translator, and
Yeah, we
Wonderful.
actually, very interestingly, every Tuesday I have one of the Russian cardiologists who brings about 5 to 6 cases, and he stays here till the cases are done. So that doctor, cardiologist who is our graduate, he's in Brooklyn, he will stay like tonight. Last of his patient probably will go in the room by 11 p.m. and so if we are lucky sometimes after 12 and he'll stay till the case is done. He is so much dedicated to his patients. Okay.
Now you saw that how, I mean, normally you would have decided that you want to take your stent to the side branch first and the main branch later. But here we saw how we did it. So when you are doing PTCA, that will give you a clue which would be a difficult. Since we had a difficulty in getting our balloon across the main branch, we knew the same thing we will have when we do a stent. That's why we place the stent in the main first and the side branch later.
so this is your proceeding with SKS?
We are trying to do what is called as a modified
Right.
T,
Okay.
which means you will not have a carina. So what you do, this is the side branch? It's too long.
Yes, there's a short here. I think that was a little more overlap of the branch. So see, if we bring both of them as a V, kind of, as long as the overlap is only 3-4 millimeter, or versus we do a mini crush, that is where we are.
Modified T mini crush. Yeah.
Yeah.
See that? Some dye now.
Number question is, if you put both of them together,
Okay.
how would you? Yeah, no. I think this maybe
Your carina will be very long if you do.
Yeah. Remember, you have to come quite a bit.
Go to the caudal. So here we may be missing the ostium in this view. So just go to LAO. Just may that your ostium is fully covered for the
I
side
think,
branch.
Well,
looks good to
looks
me.
good to me.
No,
yeah.
see ostium.
Yeah, pull back 2 millimeter more.
Yeah.
And that's very important because once you're doing crush and sew, mini crush, the few cells have to come to the main vessel. Because otherwise you will miss the, good, right?
I pull back.
And make sure also in this that your main vessel, your main vessel stent is placed because you may not be able to move it. And
okay, now hold on. We don't want to truly crush the side branch. You just want no more than 2 millimeter of the side branch in the main branch.
And this is what will be called as a modified T or
mini crush.
Or mini crush.
Synonymous.
And that is what should be. There is no crush technique now. Yep.
So just cine document so that this is what it is. Yeah.
Yeah. Very good. You are in the LP. Yeah.
Okay, good.
Ready?
So now what we are doing is we are going up with the side branch first.
Yeah.
12 atmospheres. Make sure you are nicely deployed. Nice deployment.
And you can go 14 actually.
Yeah.
Go 14. Yeah.
Good.
Go up again.
14. Good.
And then you are going to remove everything.
Now the balloon of the side branch along with the wire will come out, during which time the main vessel stent may move little bit. So both are out. The stent didn't move. No. Give some dye.
But we go to the further stand now.
Yeah.
You cannot move.
I know, some dye. Just make sure you still can move. Okay. Okay, good. Go up now.
Again 16 atmosphere because these are the newer stand of the Promus element and Zion's expedition as well as integrity. In the past with the Zion's V and Zion's Prime, we were not going beyond 10 to 12 because of dissection. These are less compliant balloons and routinely going with the 16 atmosphere so that subsequent dilatation, post dilatation, the number has gone down slightly.
New wire, right?
Yep, you got the new wire.
So the side branch wire which is in the guide, we can use the same wire to recross now.
Yeah, and now a lot of people, there is a big science that you bring the side branch wire out in the jail. Now you put that wire into the main vessel and the main vessel wire into the side, and it makes sense because you want to be, because you are within the lumen, and that is the key.
No?
Yeah, guide a little bit.
Yeah, very good.
Okay.
Well, angiographically it looks pristine there, and
which will do it later anyway. Yeah, looking very good. But now is the most important step. Any trials of kissing balloon evaluation or serial balloon evaluation has excluded patients with the 2 stents. So therefore, once you got a 2 stent, then it's mandatory that you're going to do a post dilatation. Same thing is for the Excel trial. That patients in the Excel trial, if you have a single stent strategy over the left main, you can leave it. You don't need to put do a kissing balloon. But if you put a stent in the side branch with circumflex or LED, then your 2 stent approach have to post dilate. So this is the only clear-cut point of the teaching, that while you can decide not to post dilate others, that we have the main vessel 3.5, we already have that, and for the side branch we'll get a 2.75.
No,
yeah.
2.5.
2.75 or 2.5 high pressure.
No, will not go.
Yeah. No, but we'll try high pressure because high pressure should go.
Oh, this is regular.
Yeah.
so based on what you have done, probably minimal to none carina shift.
Yeah, actually, you know what? Carina looks that you see the jumbled up shadow at the ostium, and we see a very little.
And how much would you be concerned about the double lumen here?
No, there should no
be minimal, no?
We have crushed it.
Absolutely.
We have crushed it with
yeah, you are right. Means how much is the metal there? The idea is that you have a
least amount
less shadow.
Right.
See, just a very little bit on the top. Yeah.
Give me a regular balloon. It's not going to go. I'm telling you
regular.
now.
We have the regular first. Yeah.
So, I mean, a question has come, what was
2.5.
the stents you had used?
They were
Giants. Yeah, they both were Giants Expedition 2.7533 in the side branch and 3.5
33 in the main branch.
vessel.
What has been your experience with the stent, and what particular lesion types would you use it for?
Well, I mean, actually, I would say that except in some cases where you really need a stent expansion, heavily calcific lesion, we are promoting that Promus element is good, and that actually has shown with the long-term data now that after 1 year, a little bit lower TLR compared to Giants in the platinum trial, that clearly this rewiring and going through the main strut always remain issue. So the some of the osteal lesions and some of the calcific lesions, we definitely want to. I think many times when your balloon does not go, you should rewire it. But otherwise, I think they're quite comparable. I think the enough data we have had now for both all three of them, Resolute, Promus element, and Giants, that they very dependable. Keeps the side branch patent compared to first generation stent. We used to knock out a lot of side branches. That all are very good, and all of them can get you a 3 millimeter nice side branch lumen, because the stent cell design will permit nicely the 3 millimeter opening without without major disruption of the stent integrity.
Anu, did you think you were through the struts there?
We were to the struts,
Okay.
but same.
2.0
I would take a 2.0.
Okay,
Give me
we
a
have
2 or
only a
12.
2.0, right?
No, that is no good. You need a new 2.0. This don't cross.
Okay.
I'm
Yeah,
telling you.
this is always a big issue. Once you cross the wire, that you may need a the least profile balloon, and many times since we have the 2.0 in this particular case before, we'll try to probably go with the same and see whether it goes, and then we can use this bigger 2.75. But the question always comes that in this kissing balloon dilatation, you still have to do a high pressure, non-compliant balloon dilatation of the ostium, because otherwise your stent in that area will not expand with the compliant balloon.
So with what you have demonstrated with the modified T crush technique here, how much stent deformation do you think the side branch stent has had? Minimal?
Minimal. It's not more than it has to be less than 2 millimeter in the main vessel. So it's a minimal, and especially with this newer stent design, it's
Get a run through.
where in that area.
Side branch also, yeah. Get a new run through wire.
This tip is, I'm telling you, this fielder was there. I would have, if you had gone with the 2.0 balloon, it would be better.
Okay, now
100%.
put this one in the main vessel. You want to
That
try
the
the
tip?
yeah.
No, tip is gone. I think the main tip.
Okay. So take both out. Let's go with our run through, which we are good at it.
Let's see whether the 2.0 will go.
Oh.
What nonsense you're doing. Get us a 2.0.
May not do this.
This is
Okay. You want to go with the 2.0 now?
Yeah.
Okay. Let's go. You want to try this once again? If not, we are 2
No,
already.
it's not going to go.
But just since you are there, just try 1 second. Just try 1 second. You're there, otherwise we are 2.0 balloon ready. Okay. Take it up. Good. Fine.
all right. That
This is always the issue, and that is where I say eliminate all these steps is with the kissing stent, so you
Right.
don't need to recross and so. And sometimes it's very difficult. I remember just about 3 weeks ago, one patient we tried 1.5 hours to advance the side branch, including even Corsair on various wires, and will not go after crossing it. Yeah. And I just have to leave it, because some cases, and that has been shown, that every trial of that about even with the experienced operator, about 6-8% of the time you will not be able to do a kissing balloon dilatation. You want to do it in every case, but you cannot cross it, and therefore you cannot cross it, you cannot do it. Even sometimes we think the stent of the main vessel is not fully expanded.
What
you go
balloon
to
is
high
this?
pressure. 2.0.
2.0
So, I mean, what is the present status and enthusiasm?
Emerge.
We said
Emerge won't go. Give
Okay.
it back.
Sameen, what is the present level of enthusiasm and status of the bifurcation dedicated stents?
Yeah.
No.
Yep. I think that's still a lot of enthusiasm, particularly with the Access Plus, which has come to the fruition at present. But others still they're having a problem in trying to get how we can get this bulky device without rotation. So I think it's still a long way to go. Now, what will be the many of the dedicated side branch stents will come to the market. Then the dedicated bifurcation, and the lead will be with the Triton and of course the Sipella side guard, UMED kick. But clearly those are the one will come first. The side branch stent, dedicated side branch, they always have a little bit of a stent for the main vessel. Yeah. This is always the issue in these cases.
So this is a new 2.0.
Yeah, it's a new 2.0. What track?
Yeah, track 15.
Track 15. And we have the run-through wire in the side branch now.
I'm trying with the run through.
And what was the other wire? Where is the
fielder?
Okay. Now what we should do is that keep it there. Let's dilate the main vessel with a 3.5 high pressure. Expand in that area a little more, and many times that does help to get into the side branch. Yeah.
You have 2 or 12 or no? You have the mini track?
Then if we are going with something, then we go with the 1.5.
Yeah.
Yeah. This is not helping.
I will 1 second, wait.
A quick announcement to our viewers, please watch our companion webcast next Wednesday, March 27th, Dr. Prakash Krishnan with the peripheral-interventions.org.
Go to other wire. Yeah. So now what
Give me
we have
the-
done, both the wires. No, go on the other wire
1.5
now.
watt. You don't have a mini track. 15, 12 we need. 15 is still long.
Now go on another wire now.
Give me.
Yeah. Go in the here. Go into the run through. So now what we have done is both wires in the side branch. So now we are going into the on the run through. Hoping that has gone through the better orifice of the crushed stent of OM.
Good.
Yep.
Okay, this is the 2.0 or the 1.5?
This is a 2.0
Same
mini
2.0.
track.
Okay,
Mini track.
all right.
So now you take out the other wire and put it in the what
Main
you can-
branch.
Yeah.
Wonderful demonstration there.
Yep, go.
Good. Down.
Now you can go with the high pressure.
Now give me the high pressure first.
Yeah.
Means give me both high pressure.
Yep. Now we need to do both high pressure dilatation. Yeah, we'll go. Good.
Kissing or non-kissing?
Yeah. Now kissing high
kissing.
pressure.
Okay.
Yeah, and that's
But this is a very important point
Right.
that when you're going into the side branch, you have to try with your semi-compliant balloon first. No matter what you try to do, low pressure semi-compliant, usually unused balloon, go to the side branch, make a little hole, and now you go with a compliant balloon.
Right.
Your final kiss with a compliant balloon.
no non-compliant.
Non-compliant. Sorry. Yeah. Now final kiss will be non-compliant balloon.
Yeah, 27515 quantum apex, and we have 3.520 which we used earlier, high pressure. And we are reaching to our time so that we do this kissing balloon dilatation.
Can I hold the wire?
Yeah.
But the essential message remains that with the dedicated two-stent strategy, you must finish with the kissing.
Yeah, yeah. Actually, and hopefully the new stent as you mentioned will be a game changer.
Right.
But that still will remain. I mean, the Boston Scientific petal stent, in my opinion, had a very good because that's what we needed. 2 millimeter lip of the side branch covers the ostium, need to be put another stent, and in some % of cases, but that never, the project never took off the ground, largely because there was a lot of intertwining of the wires when the device was being advanced, even with the 8 French guide. They were actually at one point using even 8 French guide. Okay, now we have 3.5. You hold it. Yeah.
So
I want to see exactly how you position the proximal.
Main? You are the main?
Yeah, I have main. Good. So let me go first. Side branch, because side branch you have to there. Even now, they have a tendency for watermelon. So let's dilate the ostium nicely with a 20 atmosphere ostium of the side branch.
Done.
Which I have done. And now then we can go up. You actually can have main one little more pull back balloon. Few millimeter.
Good. Go.
Good. So I'm going up first. It may still will come out. Yeah,
Done.
Yep. The wire need a little further.
Yeah, good.
Yeah.
And how high are you there?
Main vessel is 14.
Yeah.
Okay.
And the side branch is 14 also.
Yeah.
So I already
Don't
opened
try
that
to go.
ostium.
Yeah. If you try to go too high, you may have watermelon and may slip the balloon. Yeah. Down.
Negative. Little edge of the main vessel with this bigger balloon. Yeah. Good. So now patient tolerated quite well. And the key is that first you open the ostium with a high pressure, your 18-20, simultaneous go 14, because otherwise what happens is many times
low pressure,
you have 2 atmosphere. There was a little bit of edge as you saw, and we commonly go to smooth out with a very low atmosphere, 2 atmosphere for few seconds, and pull back, and then we'll see.
Samin, I got a quick note here that you've already started requesting registration for your live cases course.
Yes. We actually, it's not fully ready yet because agenda is being made now, but it definitely will be available, I would say, within by this weekend.
So what is going to be your emphasis this year on?
I mean, we actually have made
Let's focus on this.
quite a bit on quite a bit on the structural heart disease, because there's a lot of demand and need. Wow.
Angiographically, absolutely gorgeous.
Yeah. Therefore, what we actually have dedicated second day to almost 3 or 4 tower cases, along with the ASD and PFOs and alcohol septal ablation and balloon mitral valvuloplasties. But more important is knowing very emerging technique of our percutaneous aortic valves, and now both Edward and core valve both are available. Both we can use at our center, and clearly will show which one fits where. All right. I think this definitely require a round of applause. How nicely the vessel looks like that its patient. I usually say the patient was born with these arteries.
Well, I'm very impressed actually with the side branch is the one which I think is looking exceptional. A summary from you, Anu. What were the things which you think the viewers should take back here?
I think we as demonstrated, how to do. I just have to briefly mention, the various terminologies that are going to be used when you are doing a double stent. And if you have a short carina between 2 to 3 millimeter, we talk V. If it is up to 5 millimeter, between above 5, we are talking SKS. So there are 2 stent with a carina formation. Those are the 2 things. The other one that we showed is a modified T. And what is a T? T means you are going to the same way you decided you are going to do a dedicated 2 stent technique. You are going to place the stent in the side branch without anything in the main branch, but you may leave a balloon in the main branch. Then you take out your wire and the balloon of the side branch, then place a stent in the main branch. That is a T. But what we showed is a modified T, where we placed both the stent at the same time. So that means your side branch stent, the main branch stent is placed at the same time. You go up with your side branch stent first, and then you take out your balloon wire, and then you go up with the main branch. In this is the same, called as a mini crush in the sense. In the true crush, you have at least 5 millimeter of the side branch stent coming to the main branch. Here, no more than 2 millimeters. So it is between 1 to 1.5 millimeter in the main branch. You go up with the side branch stent, then you completely crush it, recross and kiss like we showed here. These are the couple of terminologies used. As long as you know how that you plan ahead that you are going to go single or double, and if you are doing provisional stenting and when you do your side branch, if there is a dissection, do your dedicated a two stent technique at that time, not wait to stent the main branch. Many times that's the time you may lose your side branch.
And that precisely take to our take-home message of today's, that is appropriately done two stent strategy is emerging as the superior strategy over one stent in large coronary bifurcation lesions, which is the DK crush as well as now DK crush 3 in the left main. Hence, no longer the issue should be one or two stent. Rather, we should identify lesions which will need 2 DES like this case and plan accordingly rather than bail out strategy. The second is,
go ahead, please.
The orbital atherectomy system is heavily calcified coronary lesion appears very promising, and once available has a chance for wider acceptance because of effectiveness and simple setup and easy learning curve. Because at present, we know about 8 to 10% of the lesions are heavily calcified from the coronary point of view. But the rotablation is done in 1.8% of lesions in the country. So very little uptake. Region, wire, the difficult setup and the learning curve. And we expect that all of them will be eliminated with the optimal orbital atherectomy. So quickly go through 3 questions. The DK crush technique has shown to be superior to other stent strategy for bifurcation lesion except lower restenosis, lower TVR, lower MACE and lower stent thrombosis. Then orbital atherectomy trials have shown 9 to 12 month MACE rate of 6 to 10, 11 to 15, 16 to 20, 21 to 25 or more than 25. And then lastly, the statement about making the orbital atherectomy is true. The lumen gain is proportional to the size of the burr, lumen gain is proportional to the burr moment, and lumen gain is proportional to the burr speed. And there is some issue about this ABC, but I'll fix them, and hopefully these are the simple answers.
Samin, excellent summary. As I heard listen to your take-home message, it resonates very similar to what Antonio Colombo recently mentioned in one of his editorials about bifurcation lesions, that there are going to be several lesions where you have identified the keyword. Appropriately done, they will probably yield better results. Any other final messages, Samin? And to our viewers, the next session will be April 16th.
Yep, and actually also those, every year, but the 2 major societies of India, one is the Cardiologist Society of India and second is the India Live. I have allowed the organizers of both societies to recommend one fellow who is already in training but get brush up without even passing USMLE or exam and come here for 3 months of training and sponsored by me with all their expenses. And so starting this year, we actually already have from India Live selected last year Dr. Ravi Math. He's doing 3 months, and this is just to say that teaching and educating people globally is my mission, our goal, and we could do it even without USMLE, that making with the institution clear-cut educational program for training. But key is the decision is made by the organizations, organizers of both India Live and CSI to recommend the person for 1 or 3 months of hands-on training and does not require to be a USMLE.
Samin, just to give you a final feedback, I was in the room in Chennai when this announcement was made to a great applause. So I applaud you for excellent educational initiative.
All right, very good.
Well, thank you all, and it was hopefully you found good tips for a 2-stent dedicated bifurcation strategy. We'll be back for the next session, number 46, on April the 16th.